I wanted to just introduce myself. My name is Jorge, and I'm the program manager at Doctors for Change. And today, our goal is just to talk a little bit about the MAT Waiver Training opportunity that we've partnered with several advocates here in Houston. And we wanted to talk a little bit about that. And I also wanted to give you, Dr. Kowalczyk, the opportunity to give us just a quick introduction, because I know you do a lot of work around opioid misuse prevention and things like that. So I wanted to also hear a little bit about you so that for those watching.
Sure. Thank you so much for that introduction. So my name is Alicia Dr. Kowalczyk, and I'm an associate professor at Baylor College of Medicine in the Department of Family and Community Medicine. And I'm boarded in both addiction medicine and family medicine. I do work in the greater Houston community around substance use disorders and how it impacts patients, families, and getting healthcare providers to engage with this work as well.
Absolutely, thank you. So now we're going to proceed with the presentation. I look forward to learning more about this.
Okay, so again, we're talking about the opioid epidemic. We're going to describe the etiology and epidemiology of the U.S. opioid epidemic, and then discuss ways to effectively address that in our community. So how did we get here? So it all started back with pain as the fifth vital sign. And for those of you in practice in the 90s, early 2000s, this was introduced as a relatively new concept, asking every patient about their pain and then effectively addressing it. This was because there were a number of studies showing that patients' pain was undertreated, particularly in the hospitalized setting. So you see on the left-hand side of this screen, one study that showed patients 8 years old and older with a pain score of at least 4. It looked at 842 patients. The median score was 8 out of a 10 pain scale. 83% had their pain assessed by their care team. Only 60% received any analgesia, and the median time to analgesia was 90 minutes. So, the majority of folks were with pain 8 out of a 10 scale for an hour and a half before it was effectively addressed. And almost 3/4 were discharged in moderate to severe pain. So again, the American Pain Society in 1996, and then JCAHO in 2001 recommended but did not make it a mandate to address pain. And what we saw in the late 90s to late 2000s was that the milligram per person use of prescription opioids in the US increased 402%. And since 2011, overdose has become the leading cause of accidental death in the US for those 18 to 44. More overdose deaths happen per year in the US than the total US casualties in the Vietnam War.
Wow, well, those are definitely shocking statistics.
Mm-hmm.
Okay, let's go over to the next slide.
Yeah. So this again is just another way of looking at this data. So we see the solid line are opiate-related deaths per 100,000 individuals in the US population. You can see the dashed, the smaller dashed line are opiate sales in kilograms per 10,000 Americans. And then you can see treatment admissions for opiate use disorder also went up over that decade of 2000. So that's really where we see the birth of the opioid epidemic. This is taking a little bit longer view. And so you can see that by the 2000 teens, we started to recognize that there was an issue with opioid overprescribing, and concerted efforts were made to help physicians and other prescribing practitioners decrease or more effectively and safely prescribe opioids for pain, and particularly chronic pain. And those educational and other intervention efforts have paid off. So we see through the middle of the last decade that prescribing rates began to fall. But unfortunately, we don't see that opioid-related deaths fall at all. In fact, they start skyrocketing in the mid-2000 teens, and that trend has continued. So that curve continues to go up.
Wow.
So why did reducing prescribing not work to fix the opioid epidemic? So people that developed an opiate use disorder from taking their prescription pain medication just because they could no longer get their prescription pain medicine didn't mean that their opiate use disorder was cured. And so they turned to other more easily, readily available, cheaper alternatives, which included heroin. And then so in the mid-2000s onward, we've really seen since the mid-2000 teens the increase in synthetic opioids available in all kinds of street products. And so a little bit about the synthetics. So if heroin is twice as potent as morphine, fentanyl is 100 times as potent as morphine, and a lethal dose, which is 2 milligrams, which is equivalent to 2 of these little grains of salt that you see pictured here. Very tiny, it takes very little to really lead to overdose. And carfentanil, which comes through communities periodically, another synthetic, is 100,000 times as potent as morphine. A lethal dose is 20 micrograms, which is equivalent to the size of that snowflake that you see pictured here. And there is the business model for why are the synthetics taking over. So you can order right off the internet, of course, a pill press for about $1,000, cranks out about 5,000 pills an hour. For $250, you can get dye molds to make your product look like whatever you want. For about $100, you can get 25 grams of fentanyl, again, off the internet, dark web. And if you mix in another $900 worth of other chemicals, etc., you make a 1 milligram per fentanyl pill so you don't kill your customer. That gives you 25,000 pills at $10 a pill on the street. And so you have a cool $250,000 for your roughly $2,500 investment. And so again, we're seeing fentanyl not just in things that are marketed as opiates on the street, whether it's heroin or different prescription pills like OxyContin, Vicodin, Narcos, etc. We're seeing it in benzodiazepines like Xanax, and throughout the illicit drug supply as well.
I gotta say, this is our 4th time hosting this this presentation, and every single time I host this, I learn something new every time. So this is definitely some very interesting and very important information to know about just how strong this stuff is too, and why it just kind of relates to the data that we just saw as well.
Thank you. And so these are pictures of recovered counterfeit drugs from here in Houston. All of these, when tested, contained fentanyl, although none were marketed as such. And this is, again, the dye molds that you can purchase to make your product. And you can see all kinds of product packaging, so to speak, is available.
I never knew they also have different impressions of like characters like Mario and Hello Kitty. Wow.
So where are we now? So this is some review of an overview of national data. We know that overdose is the leading cause of death for people under 50 in the US. US overdose deaths in just 2019 were 71,000, and that exceeded again total US casualties during the entire Vietnam War. AIDS-related deaths in 1995, which was the worst year for AIDS-related deaths in the AIDS crisis. The peak year of US homicides back in 1991, and suicides, which continue to rise, but we're at 44,000 in 2015, which is the latest data available. For the first time in modern US history, we saw life expectancy decrease for younger generations, primarily driven by overdose deaths. We've seen another layering of a decrease in life expectancy from the pandemic, from COVID-19. And overdose is now the leading cause of perinatal mortality for women. Every 25 minutes, so roughly twice an hour, another newborn is diagnosed with neonatal abstinence syndrome. So there has been some progress on the opioid epidemic with prescription pain reliever misuse. And so we know there's been a modest decline overall for each opioid category except prescribed fentanyl, which has no change and was most often used, prescribed fentanyl, in end of life and cancer care. This is another look at the 2019 data from the National Survey of Drug Use and Health put out by SAMHSA. You can see that pain reliever misuse continues to decline. Use disorders, pain reliever use disorders has declined modestly, but we see at least it's heading in the right direction. Heroin use has declined, heroin use disorder has declined, and so have people new to using heroin. So those are all positive trends. Again, looking at the opioid use disorder data by age group, we see that youth have really heard the message about the opioid epidemic and are staying away from opioids. Young adults as well. We see less of a decline in those that are past early adulthood, so 26 and older. And then when we look overall at 12 or older, it moderates out a bit. We also see some gains in the number of people actually getting treatment, effective treatment, medication treatment for opioid use disorder. So you can see more people are getting on methadone, getting access to buprenorphine, and a little more modest rise for naltrexone. Those are the three medications that are FDA approved to treat opioid use disorder. So some key take-home points about the data from the National Survey on Drug Use and Health. Opioid use disorders decreased significantly from 2 million to 1.6 million. Efforts to increase access to medication treatment, psychosocial and community supports has really made an impact. But despite these gains, opioid overdose increased in 2019 by approximately 4.6%. So again, those illicit synthetic opioids and continue to drive our need to engage people in care. So what happens with an epidemic and pandemic meet? So that was all data pre-pandemic. We do have some early preliminary pandemic data. We could maybe predict an increase in substance use and overdoses because it's just been really stressful, and stress sometimes drives people to relapse and to, if they're already using, to use more. Stress related to financial strains, caretaking strains, being isolated from a recovery community, changes in what substances are available. So again, with relative small quantities needed to make a robust profit, we see fentanyl is a lot easier to transport those type of quantities needed than, for example, heroin. And so we're seeing an increase in synthetics in our drug supply. And we see a decreased access to care, people losing their insurance because they've lost their job during the pandemic. Many treatment programs have limitations on new patients to try to maintain pandemic related safety precautions, and all that adds up to decreased access to care. So we do have some preliminary data from the Western US, including here, right in Harris County. We've seen a 63% growth in fentanyl mortality across the western half of the US. And fentanyl, again, we're not seeing just in heroin or prescription opioids. We're seeing it in other prescription pills like benzodiazepines, muscle relaxants, Again, all from the street, marketed as not an opiate but containing fentanyl, and even in stimulants like methamphetamine and cocaine. And so recommendations include increasing the standard dose of naloxone in patient formulations commonly used by first responders, expanding access to care through expanded healthcare coverage, especially for medication therapy, and then public health education campaigns needed. And here in our very local area here in Houston, HFD has reported a 31% increase in overdose calls year over year for the first 2 quarters of 2020, so January through June. So taking a little broader picture, for the whole US, all substance overdose deaths reached a new peak. So before we had 71,000 deaths in 2019. Looking at June 2019 through May 2020 data, we reached a peak of 81,000 people dying of overdose. And largely this was driven by the increase in the months of 2020. So those first 5 months of 2020, you can see 13.2% increase in overdose deaths across the country. And we're pretty close to that in Texas. So we're at 13.8%. Although likely we underreport statewide, we do not have robust reporting mechanisms for overdose and attributing deaths to overdose. So that's likely an undercount.
And you worded this really well during another presentation. You mentioned that we're fighting a epidemic and a pandemic, so it's an ongoing battle to try to fight both of those things at the same time. But the work that you are doing is definitely key, and as you see, the trends are really affecting the work that you are doing. So this is all hopeful information.
Thank you. So how do we help our patients, our communities recover and sustain recovery, sustain health? So one of the ways we can do this in primary care is to better and more effectively address pain without opioids. We do know there is now little role for opioids in treating chronic non-cancer pain. We know that most acute pain requires a maximum of 3 to 7 days opioid management. Giving someone a script for 30 days of opioids for acute pain dramatically increases their risk that they'll still be on an opiate 6 months later. And really linking those already with an opiate use disorder into treatment, especially medication treatment. We can also help prevent overdose fatalities and link people with opiate use disorder to care. So making overdose prevention and response, including naloxone kits, readily available throughout our community and certainly with our own patients, and increasing treatment resources within the community. And this includes incorporating opiate use disorder treatment in our own primary care practices. So how common is pain? We know that 60 to 80% of us here in the US will have chronic pain at some time in our lifetime. And many patients with substance use disorders report chronic pain. We lose over $60 billion annually in productivity to chronic pain. And actually the most common chronic pain is headache. We often think of back pain, but it's actually headache and then back pain, other arthritides and joint pain. What we've seen is a real evolution of prescribing guidelines. So back in the 90s and pre-90s on into the early mid-2000s, we see that a lot of the prescribing guidelines were industry funded. Now they're not. We used to talk about risky patients, so screen your patients and maybe this patient wouldn't be a good candidate. Now we talk about these drugs are risky for anyone. Certainly there are patients that are more likely to be at risk, but anyone taking an opioid can develop an opiate use disorder. We used to talk about really no upper limit in terms of safety, as long as the patient needed it for pain. to now really 50 milligram morphine equivalents being a real ceiling for that and for crossing over into high risk. And then we went from, you know, believing that opioids were really helpful to treat chronic pain, non-cancer pain, to that, well, they may play a role sometimes, to really that they're pretty harmful. And for most folks, you need to avoid this. The risks don't outweigh, the benefits don't outweigh the risks. So the CDC guidelines in 2016 really stressed all of this. Non-pharmacological therapies and non-opioid pharmacological therapies are preferred. These risk assessment tools for our patients are not so helpful. It really is risky drugs. And then 3 days is typically sufficient for acute pain. It's 52 pages long. The Crib Notes version is on page 16. It's a really great resource. So the Veterans Administration and the Department of Defense published similar guidelines in 2017, again stressing avoiding long-term opioid therapy to treat chronic pain, offering overdose education and naloxone distribution to anyone on chronic opioids, and medication treatment for patients with both co-occurring opiate use disorder and chronic pain. Again, a pretty lengthy report. It's excellent, but maybe a little much to wade through. I have a 7-page pocket card. I put a link to the guidelines here. That's really great, walks you through steps of how to assess and evaluate for chronic pain. So really what we're trying to move from is not just kind of band-aiding over the chronic pain with an opioid, but interrupting that chronic pain brain. We know that there's a lot of neuroplasticity, and activation of the pain centers increases 5-fold in transitioning from acute to chronic pain. So pain changes the brain, so we really need to help the brain, use the brain to change the pain. So pain can really lead to a lot of fear, avoidance of activities. Those decreased activities would lead to decreased socialization, which really heightens people's pain, that isolation, which is again another reason that it's become such an issue during the pandemic. If instead we interrupt that fear with mindfulness, keeping the body moving through the pain in a supportive, safe way. For example, with yoga, we see increased function. We see that people maintain or increase their socialization, and that results in decreased pain. So these are all non-pharmacological treatments for chronic pain that have been shown in randomized controlled trials to be as efficacious as an opioid. So we have cognitive behavioral therapy, dialectical behavioral therapy, acceptance and commitment therapy, fear reduction, mindfulness meditation, yoga, and structured exercise programs. Specific guidelines in Texas, we are limited to 10 days for a new start of an opioid for new scripts. And we must check, since March of last year, the prescription drug monitoring program database each time an opioid is prescribed. Naloxone is available by statewide standing order at every pharmacy in Texas that carries it. Patients just need to be directed to go to their local pharmacy and ask for it from the pharmacist. They have to pay for it, but it is available for them under standing order. So what does an effective community response look like? So really, it's a multifaceted approach. We want to ensure judicious prescribing of opiates, checking that PDMP, making sure that we're all up to date on the latest guidelines and how to do monitoring, and really monitoring our own practice. Direct opioid overdose prevention, clinicians, pharmacists, first responders, and general layperson education is important. If you are prescribing someone an opioid or treatment for opioid use disorder with an agonist or partial agonist, methadone or buprenorphine products, then you want to co-prescribe naloxone. And we want to get naloxone distributed to lay and professional first responders in our communities. There's also, can be very helpful to have prescription drug disposal and give back programs, which are generally coordinated in most communities by law enforcement. and then really want to intervene and link people with opiate use disorder to appropriate care, giving real-time access to treatment. Again, trying to move this into primary care so that patients don't have to go to a separate place to get their treatment. Ensuring access to peer recovery support. And again, medications are now the gold standard of treatment for opiate use disorder.
And I believe that was the last slide, opioid epidemic solutions.
Okay. So I invite everyone to who is a prescriber here in Texas and the greater Houston community to get a waiver to be able to prescribe buprenorphine in practice and treat patients with opiate use disorder in practice, also called office-based opiate treatment, or OBOT. And our next training is coming up this Saturday, February 27th, I believe, is Saturday.
Yes.
From 8 a.m. to noon, and you can sign up through the DFC website.
Absolutely. So we invite everyone to join in and be a part of the cause.